Thank you so much, everybody, for joining us this morning. We right now we're connecting with everybody in a hybrid format. So here in person in Charlotte, North Carolina, but also in the room today, particularly in our Zoom room. So we're doing this virtually and we're doing this in person. But I went ahead and started recording so that way, if anybody wants to view this later, you can as well. What I was going to share was, so this presentation today about mapping key points of survival for older LGBTQ plus adults of color is contingent on a conceptual framework, particularly that Nicole Silverio and I not only worked on, but also has served as a foundation for one of our research studies. So we're conducting two research studies right now, both qualitative in nature that focus on older LGBTQ plus adults of color and their caregivers. And so I think in many ways in the process too, that we're constantly transformed. And I think that has been an exciting part of how we've had to even redefine our own notions of survival, and what that ultimately means for the community, and how I think for me as a queer person of color, but yet someone who's much younger, right, and doesn't live in this generation, has to even just rethink my own definition of survival. So just continuing to develop so much appreciation throughout the process in this both qualitative research studies. So I think in that vein, that's where this comes from. Part of what we'll tackle today is an overview of some of the key issues facing older LGBTQ plus adults of color, particularly what's covered in research, gerontology, health research, health equity research. So just seeing this across a whole broad spectrum. Unfortunately, I'd like to see more in the counseling research like domain, right? So I think we're excited to embark on this journey and continue solidifying this as an area of scholarship for me and Nicole. But the one challenge is that there isn't much, both conceptually and empirically, which does have me concerned. So it's making me excited, but also has me concerned. And at the same time, older LGBTQ plus adults of color, there's not much empirically, particularly even in other disciplines. There's a lot of focus on older LGBTQ plus adults. And I think the other piece too that I wanted to highlight from today is certainly making that transition when we talk about minority stress and health inequities, that we also distinguish between trans, non-binary, and gender non-conforming, in addition to LGB, right? LGBTQ, because I think that there's different particular, not just challenges, but when we think about genderism, it's very much even more so, right? More exacerbating, but also there hasn't been research and interventions to cover how to tackle genderism as a part of the process. The other piece that I wanted to highlight was that Nicole couldn't be here with us in person today, but certainly she is here with us in particularly, and I also wanted to give her a huge shout out for the contribution she's given to the presentation. So I certainly very much so a co-partner in our research together. So first, I'd like to talk a little bit about minority stress, right? So if anybody's familiar with the minority stress theory framework by Ilan Meyer, like pretty much coined, developed, refined by Ilan Meyer, who works for the Williams Institute. And he does a phenomenal amount of work, right? Like creates brief reports, creates policy reports, does a lot of advocacy in the midst of scholarship. And so I definitely recommend, especially if you're looking for overarching trends. So not just like, okay, what's published in an empirical journal, but if you're looking for overall trends among LGBTQ plus communities, I would definitely go to the Williams Institute. It's a phenomenal resource. And you can do searches, like for example, if you're doing work on substance use, if you're doing work on addictions, if you're doing work on HIV, certainly any topic that comes up, they might have a brief report that covers it, right? Or a statement, right? A position statement. that covers it. So that certainly could be a robust resource for everybody here. One piece that in terms of minority stress, so Ilan Meyer essentially developed the framework, right? It's been applied in so many ways as we think about minority stress and the experience of minoritization. And really, the language that Ilan Meyer uses is discrimination. And so discrimination and stigma. And so now it's been certainly applied in so many other scopes, right? In terms of when we think about different social identities that we carry. But the first way that he conceptualized minority stress was in application to LGBTQ plus communities. And so in many capacities, he noticed that, you know, in many ways, heterosexism and genderism play a huge part in physical health and mental health. And then it cascades into a number of other effects and behaviors and interactions with the healthcare system that also then adds on, right, to physical and mental health. So that's essentially what we're seeing, right, is that we've known this for some time. When we think about LGBTQ plus older adults, that it's continuing to increase in focus, both in policy and research. And at the same time, I think that it's still very slow to adapt, right, in our training and our understanding. Like when we think about, just like as someone who's taught the multicultural course for several years, right, that we tend to focus on distinct social identities, which is helpful, right? And that's how much like we're applying in that moment, but then we tend to lose sight on age as a social identity. And particularly when what I want to highlight is that social force of ageism. And so that often gets, I would say, removed from the curriculum, not necessarily intentionally, but something that certainly comes to fruition when we think about LGBTQ plus older adults. The other piece too is, so when you think about LGBTQ plus older adults, the reality is you're going to see a constellation of health disparities and chronic stress. So for anybody who's really thinking through and conceptualizing trauma-informed practice, right? That when you think about this, right? So we know, like, if anybody's heard not just the term like chronic stress, but also toxic stress, it's like that notion that the amount of adverse events, right, that you experience over your lifetime. So in this way, if you think about all the discriminatory events that LGBTQ plus older adults face over their lifetime, it's going to affect and impact their physical and mental health. And so of course that like leads to all these other health disparities. And the other piece too is that when you think about LGBTQ plus older adults of color, so they're at the nexus of racism, genderism, heterosexism, and ageism. I think in many capacities, this is like multi-layered, because when we think about it, it's not just the experience, right, of like, I'm experiencing multiple discriminatory events at not necessarily all at the same time, right? But I'm bracing for it every single time. I'm preparing for it in every single context. The other piece too is that realizing, you know, there's not enough training that has covered, like, for, you know, and this is a problem too, right? That as we think about training in not only in gerontology, but also in counseling and research, right? In other healthcare disciplines, is that when you think about culturally responsive care, they're often tackling one social identity, not necessarily the intersection of these different forces of oppression. So that's the other piece. So if we want to think about how do I embody this in my own practice? How do I think through this? And what do I do in my clinical services? Really think about, okay, well, what are all the barriers that we've already set up, right? And what's the gap? What are the gaps in our training for culturally responsive care? And of course, as we think about this too, right? So I'll talk about this as we come to the next slide on social determinants of health. But the other piece here is thinking about the predisposed risk to COVID-19. That is a very relevant and real experience right now. As we think about LGBTQ plus older adults of color, like we know that as we think about social determinants of health, that racism, right, plays a huge part in COVID-19 deaths and mortality and risk. Um, we also know that, of course, like as you think about this, like when you see that intersection, right? So now we're thinking about um, if we think just here about older adults of color. So there's already like racism plays a huge part, right? In terms of like housing conditions, in terms of mortality, in terms of risk, because of all the different like experiences of race-based trauma that someone might encounter during their lifetime. So there's that piece, but also the other example I'll offer here is when someone's bracing for heterosexism and genderism, their risk for COVID-19 dramatically increases, right? Because they're bracing for, I'm going to go to a healthcare, like, why would I go to a healthcare provider that's probably going to harm me, that's probably not even going to care? And so there's less likelihood to participate in those services. So if you think about it, it's this multiplicative effect that happens. The other piece I wanted to highlight as part of minority stress theory and the conceptualization, those basic definitions, right? So there's the distinction between in minority stress, right? That minority stress can show up in two ways. It can show up as a distal stressor. So what that means is that it's like an objective event of discrimination. It could also be something that you witness personally, right? So say for me, like I was seeing, in the same room as another colleague of color, and they were basically someone else was basically spewing out like microaggressions, racial microaggressions. And so that is the considered the objective event, right? That's like what happened. The other piece here is proximal stressors. So now how do I internalize that event of discrimination? So now I'm like, it's like, oh my gosh, like not only did I witness that, but then as I experience it, like it's like my emotional well-being, right? I'm like, now I'm feeling stressed by it. So that's what the proximal stressor is about. The one piece that I also wanted to add in terms of minority stress theory is that, you know, I think sometimes it's easy for us, especially when we try to merge minority stress and intersectionality, that sometimes it's easy for us to think, oh, well, it's an additive model, right? That racism, heterosexism, genderism, and ageism certainly only show up in as like you'll experience just more oppression, right? And the other piece that, you know, I would say Elon Meyer has done in the last 1 to 2 years has tried to reform the framework in a way that, yes, like we have to acknowledge that like the experience of brutality, the experience of violence, the experience of discrimination, certainly we have to validate those experiences. And at the same time, Elon Meyer is also making room for resilience as a part of minority stress. And so particularly as we think about this, right? Like for example, LGBTQ plus older adults of color, and I'll give some examples from where we're at in terms of preliminary findings with the research. But what was really important to us was just even hearing, right? Like the ways that LGBTQ plus older adults of color navigate, have navigated discriminatory events over their lifetime, have navigated violence over their lifetime. That has helped also to create or cultivate that meaning of survival. And certainly like how do I now brace and prepare myself to know how to resist the system, right? But also how to creatively navigate the system. And so it was very real for me and Nicole to really process that as we're seeing that from participants. So if anybody's familiar with social determinants of health, so I want to highlight, right, that physical and mental health don't just occur in isolation. When you think about it, I even think about what happens, right, when social determinants of health, how it impacts our access to care. So as we see that like access to care is impacted by where there's like mental health shortages, right? Like, or mental health care shortages, particularly as we think about rural communities, that might impact, that's a social determinant of health. Like it might impact how people can even access their care. What kinds of care providers might they have available to them? Because if you think about a rural environment, I mean, this is why I remember teaching the ethics course for 3 years, right? And why I was so adamant that, when students, of course, like they were walking through their process of understanding how do I navigate like my own like values conflicts. And it's like, okay, I can appreciate where you're at developmentally, but I always put it as like on their conscience, right? Like in terms of like morality, and really helping them to understand. Just imagine what you do if you refer someone out, that you could have been the person that saved that person's life that day. And when you refer them out, you're sending a message to them. If you're and then if you refer them out, how many, I mean, especially in a rural environment, how many care providers are they going to have access to? You could have been the one that saved their lives. So I think that's always why I leave that. And that's a good example of a social determinant of health, right? That we often see like these other barriers stacked and mapped onto physical and mental health for those reasons. I think the other piece too, and this is what I want to hone in on, and I hope that you can take this away in any setting, whether you're teaching, whether you're researching, or whether you're practicing, that I think it's important for us to tackle literacy, like literacy not only on healthcare, but also like on physical and mental health, but also literacy on access to care. And I think that's important for us to take away from today's conversation, because so many LGBTQ plus older adults of color, it's not necessarily that they don't know like how to access care, but it's like they don't always have the resources. And I think that's important for us to highlight, or we don't often bring that into our conversations, right? How they've already cultivated the resources for themselves. And so again, to pull from that resilience and that navigational capital, really to walk through and explicitly broach that. Because I think we tend to sort of say, oh, well, yeah, we're not going to talk about that today. But I think that literacy on healthcare and healthcare access can be so important, because it's not just about, like, when we think holistically, right, as counselors, that yes, we're attending to wellness and mental health, and at the same time, there's these other factors that are going to impact wellness and mental health. Mm-hmm. Right. Right. Oh my gosh, I so appreciate that, because I think in many capacities, are like, when we think about clients that we work with, whether it's individual, couples, families, that many of our clients that we work with, it's easy for us to say, I'm going to give you 3 referrals to like different care providers. And even though I'm still your acting counselor, but then really talking through like, okay, like what might you look for in a care provider? Because if you can imagine, the reality is, like, if you go to a care provider and they're going to be harmful towards you, it's like, it's not going to help that process either. And it also can create some mistrust in your relationship with the client. So there's that piece too. I think in many capacities, as we think about trans people of color and queer people of color, the reality is, like, even across a broad spectrum of the lifespan, that healthcare access and social determinants of health, what has been really important is actually affirmative care providers. And when you have that actually culturally responsive care, Flynn and colleagues actually talked about this, that culturally responsive care is what could buffer negative healthcare encounters. I'm really appreciative that they provided evidence behind that. So, but as we think about this, the other piece too is, like, we can talk easily about, like, we know we're talking about access to care and then health insurance, but one of the pieces too is food insecurity and housing. So if somebody's literally saying, I can barely think about healthcare right now. I can think about barely about going to a general care provider or even like a professional counselor right now. I can barely think about that because I'm literally just trying to like survive, right? I'm just trying to provide for myself. Trying to provide for my family. So if that's unstable, right? If like the housing options are unstable, that certainly could be a concern. And then of course, when you think about food insecurity, it starts to exacerbate like other underlying medical conditions. So when you think about hypertension, cardiovascular issues, diabetes, like it's like that's certainly going to like we can't like that part of our nutrition and our wellness, right? We can't always attend to. So particularly as we think about this, right? I put this together in terms of mental health and substance use. So there's this cascading effect here when we see like white social determinants of health and minority stress and how they converge for in terms of mental health, overall mental health. One of the key pieces is that we know that, of course, like stressful events definitely like lower outcomes of wellness. And what they do, how they increase mortality, is like that long chronic experience of stress. So it impacts physical health, right? And mental health, but also increases suicidal ideation. So when we think about it's not just like older adults, right, who are experiencing like increases in suicidal ideation, but when you think about it, like what kinds of resources and supports might I have? And what are some other ways that I'm preparing to just like experience other forms of discrimination? So there's increases in suicidal ideation. Um, so talking about this, like, of course, like talking about obesity and chronic illness, like the culmination of stressful events, right, can add to like stress within the body. And so it certainly affects the way that we think about some of those other underlying medical conditions. So when we think about particularly here that, you know, stress often leads to like, you know, that sometimes it's not just like, oh, like I had genetics, right, within my family that predisposed me to underlying medical conditions. Sometimes it's a culmination of stress. Um, I can even remember, like, so I remembered going to a care provider and they just told me, you know, it was funny because I was like, I know it's like, it's because of stress. And they were saying, oh yeah, stress makes everything worse. Like they just said like general, like put like apply to every single underlying medical condition. Stress makes everything worse. So when you think about like what I experience as like how the way how I internalize it in my emotional well-being, my mental health, it's often going to impact my physical health. And that's what, of course, like when you think about that culmination, right, over the lifespan, that's what increases mortality too. The other piece too that is of important note to explore, particularly for older LGBTQ plus adults of color, is that, you know, when we think about not just like physical and mental health, but also cognitive decline, right? So of course, like the stress that adds on, like, and we know that dementia is often attached to like physical and mental health. And so the cognitive decline over the lifespan is often a result of that stress, right? Um, and because someone's not necessarily like if they don't like have access to care within their own like networks or families, it certainly can mean something very different for them. So this is the other piece that I also wanted to highlight in terms of thinking through access to care. So it's not only right that we're thinking about like I'm going now to a care provider and I'm going to experience discrimination. The fact that I'm often thinking of and deliberating how many care providers are there really going to be that are going to affirm my identities, that are going to affirm my intersections. If I don't have that, then I'm less likely to seek care. Why would I do it? It's like, why would I put myself in that position? So if you think through that thought process, that might be occurring as well. Or on the other hand, sometimes it's like, okay, I know I need this right now. Like I know I need medication. So I'm going to subject myself to go to a care provider that's going to, I know they're going to be toxic for my well-being, but I have to do this. It's like, what sacrifice am I willing to make? And so having to negotiate that, right? The other piece here is there's a significant lack of training on culturally responsive care with older adults. And I think we see that, of course, right? Like we're thinking right now for healthcare providers, like there's like, okay, so, and I really encourage, like, if you can find or partner with a LGBTQ center or community organization that even advocates, sometimes what happens is that they also create networks of care providers so that not only you can refer to each other, right? But also, so this is people who are part of the communities and people who are allies. And what I find so profound as part of that experience is that everybody's so committed. And so it's not just that people are just like, oh, I'm going to refer to so and so, right? Or this is just part of my network. But the reality is that there's a lot of consultation that's happening and making sure, like, what am I doing to make sure I am providing not only resources, but like sort of like a mutual aid, right? Where like I'm really helping to walk through like what are my own biases um, and not making sure that doesn't manifest in my work or knowing how it might manifest in my work with my clients or my patients. The other piece on access to care is this reality of living alone. That has been an important issue that we'll talk about in the other study we're doing on caregiving. So one of the key pieces is if somebody's living alone, that certainly impacts their access to care, right? Or their likelihood to even access care. So even integrating this into an intake or even discussions, it may not be in your intake, right? But really talking about like, what is like the housing situation like for that person? I think we tend to just focus on like mental health symptoms, right? And I understand why we do it. But we think about older LGBTQ plus adults of color who are just living, right? That is their means of survival. It's like, I'm just trying to live, like, and I'm trying to navigate my housing situation. And so if we don't even bring that into the conversation, it may never come up ever. Okay, so the other piece here is I wanted to highlight some of the key issues that also show up for older LGBTQ adults of color uh, as we think about housing, right? And housing situations. So there's certainly different living environments and conditions. So sometimes people live with caregivers, and that could be formal or informal caregivers. They might be living by themselves. They also could be living in assisted living environments or nursing homes. And so there's that possibility too. The other piece, like, so Hafford Leachfield actually talks about this in their study, that there's a significant amount of like it's like, so we're talking about healthcare access and healthcare providers not having culturally responsive care. But here's the other piece that we need to tackle too is how are like nursing home workers, right, also trained? Because I think we tend to forego that as a part of our process. Like, oh, let's like tackle like mental health and physical healthcare providers. And but like in these living environments, like how are we actually tackling and dismantling some of those different forces of oppression that take place within a nursing home or an assisted living environment? The other piece too is that I think in many more recent studies, especially like I definitely recommend looking at Jennifer Putney's work. Amazing work. But what I will say is there's a lot more visibility right now on like potential abuse and mistreatment in nursing homes, like, and particularly abuse and mistreatment of older LGBTQ plus adults. So there's a lot more concentration on research that focuses on those experiences. The other piece is what I also want to highlight is that why not just older LGBTQ plus adults, but older LGBTQ plus adults of color are essentially bracing for, they're also bracing for potential abuse and mistreatment. Like, so it's not just the experience, they're bracing for like, I'm gonna move into this living environment that I'm not even sure it's gonna be safe for me. So there's that piece too. And sometimes this is the part that also really breaks my heart, right? Is that to even enter into a safe living environment, what older LGBT plus adults of color might do, they might conceal their identities. And I think that and I'm gonna reference now, sorry, this is a little bit tangential, but even referencing like the preliminary findings from our study, like the reality is like identity plays a huge part. Labeling, claiming your identity plays a huge part in survival. And so this is diametrically opposed, right? When you have to conceal your identity, it's so harmful to your well-being. And then of course, the other piece, you'll see this highlighted in bold here, but the reality of like being not only evicted from your current housing environment, but also realizing like it may not be just the eviction, right? But there's other barriers that could be stacked, right? So people get creative to be harmful. Sometimes what they do is they deny the housing application altogether. Or what they do is they say, oh, well, you know, suddenly we've created an increase in your payments. Sometimes they could create an increase in your rent. It's like arbitrarily. So this is where, as we think about what a key issue is in terms of survival for older LGBT plus adults of color, one of the key issues is that, you know, we talked a bit about living alone, perhaps like not having many family supports or having to get creative, right, about who my family supports are, who my community resources are. The reality is we know that this is a pervasive issue at this part of the lifespan in the terms of transition to older adulthood, is that, you know, for example, like 35% of adults over the age of 45 and 24% of adults over the age of 70 report feeling lonely. So that loneliness is a key issue. Social isolation is a key issue. And as much as we want to say that, yes, like kinship is a huge part of LGBTQ plus communities, it's a part where we often also have to navigate, okay, what's the experience of me going into this transition in the lifespan, feeling lonely, but also finding like, do I still have my community here with me? So as you can probably imagine why the mixed findings exist. And part of it is because it's like, yes, like I experienced this individually as I transition into the stage of the lifespan, but also drawing that, you know, from this collectivism, right? And that kinship, knowing that, you know, I really, like, this is what I've lived with my whole life. And so often we think in that mindset first to, sorry, I think somebody was trying to open the door from the other side. So that's where some of those mixed rates or mixed findings might come from. So the other piece is in terms of when we just narrow the scope, right, on LGBTQ plus older adults. So their choice is likely to live alone. So there's probably a likelihood that they might be living alone. They may not have a partner. They may not have other family members. They may have been rejected by other family members. They might also, again, like they might have access to other like colleagues and friends and family members, but they may not be right nearby. So that's the other piece. They're also 4 times more likely to not have children. And so there's that other piece, right? Like when we think about intergenerational supports that we may not see, like, okay, well, sometimes like, you know, as I transition, like my kids might take care of me. And we know that's not always the case, right? But at the same time, sometimes there is that level of support where my kids might take care of me as like their parent. So, the other piece here that's an overarching trend in the research is, so we talked a bit about this, right? Like family rejection plays a huge part in terms of that loneliness. Like how it exacerbates loneliness is family rejection, and even not only like family rejection in that moment, but drawing from experiences, right? Because I often hear this where a lot of people say, well, you know, isn't it better now in 2021? I was like, but think about what someone had to live through 40 years ago. Think about what someone had to live through even 30 years ago. It's still, they carry that experience of pain with them. those stories stay with them, and they may not at any point have had the opportunity to share that. And I think that's where we think, tying this to our role as professional counselors, why it's so important to really allow, like, to be like good listeners, right? Because sometimes the ability to tell those stories is a part of survival. Um, and I think in many capacities, I was hearing that from, I can remember a participant in particular who shared that, the ability to carry the stories is a gift, but to be able to tell it is, that is survival. Um, and of course, we also talked a bit here about like thinking about your family, right? Like who is a part of your family and how you redefine that. And drawing from that as a source of strength and support. Okay, so the text might be a little challenging to read here on the larger projector. So I'm gonna read some of it out. But one of the focus of one of our other studies is on informal caregiving for older LGBT plus adults of color. And so essentially, and this is where, especially as we think, right, like think about all the constellation of different pieces of social determinants of health, and think about like all the different ways that we think about cultural aspects, right, of our well-being. The reality is, like, of course, like it makes sense, right, where older LGBT plus adults of color, yes, might have a partner, a family member who might be a caregiver, a friend, right, who could be a caregiver. um, and that's where that informal caregiving really comes from. So it may not be like I'm paying for a formal caregiver, but I may have a friend or a family member who's providing informal care for me. Other trends here is that 60% of caregivers are women. The other piece too is that 86% are relative of the care receiver, right? So the 47% here, they provide for care for a parent or a parent-in-law, and 11% provide care for a partner or spouse. 55% of care receivers are over the age of 75. So, and then of course, like, so this is like, I think for some of our colleagues here, even at the conference, right, they're very invested in caregiving, but also understanding caregiver burden and caregiver stress. So one of those trends, right, is four in 10 caregivers for older adults are over the age and report in their care that consist of high burden situations. So it often feels, right, like as a caregiver, I'm also under stress, or I'm concurrently experiencing that stress too. And that could mean, it's not necessarily the stress of like, oh my gosh, like I'm navigating this financial or housing situation with you, but I'm living the discrimination with you, right? It's hurting me to see you feeling hurt. And so with that being said, so that also illuminates this too. 4 in 10 caregivers for older adults say that their caregiving situation is highly stressful. And then as we narrow this down, right, for caregivers of BIPOC and LGBTQ plus older adults, there's a significant concern, particularly for caregiver availability. And I think this is what I alluded to earlier, right? It's that as much as and this is what makes it so challenging, is when you talk particularly with older adult clients, they might say, yeah, it's not only just that I live alone, and yes, I might have access to a caregiver, but the caregiver availability, the person who I trust, right, who's a part of my network, like that is important to me, and it's stressing me out that I don't have someone in my life who's easily accessible to me. So again, there's concerns of caregiver availability. The other piece, like around social support. So we talked about social isolation and loneliness earlier. And the other piece here is that for LGBTQ plus older adults who are over 50, mostly they care for each other. So again, this is where I think in terms of expanding upon that, as you think about relationships and social supports for in counseling, right, is really thinking through like how perhaps like they've either personally experienced care or providing care, or even knowing others in their networks who have provided care. I think that's the other piece to continue expanding social supports and resources. Because if you think about it, right, so here in terms of this trend is 60% of caregiving does come from partners. Like that is a piece that has been expanded conceptually and empirically in research, particularly around caregiving for older LGBT plus adults. So part of what spurred our research, right, was that there wasn't something that actually quite tackled the intersection between LGBT plus caregiving and caregiving for BIPOC older adults. It's pretty compelling right now. Like, it's striking to me that there hasn't been anything that really expands upon that, right? And certainly, as we talked with community partners within our local North Carolina area, we were talking, and that has been not only have community partners have become more excited about the research because they're like, yeah, I mean, people often talk broadly about LGBT plus older adults and caregiving. People talk broadly about BIPOC older adults and caregiving, but we're not seeing that intersection right now. And I hope that's what we continue to illuminate. And so, yeah. And so similarly, as we think about BIPOC older adults, because of that mutual aid, and because like mutual aid perspective, and because of the collectivism and that social capital piece, the familial capital piece, what's so important is that, you know, often we rely on family members and friends. We rely on, whether it's children, whether it's siblings, whether it's other family members, really to serve as that support, rather than saying, okay, well, I'm going to pay for, even if it's not like, even if it's covered, right, by insurance or like by another resource, that I'm going to rely on a formal caregiver. In most cases, it may not be that I rely on a formal caregiver, because how am I going to trust them, right? But the reality here is, both for the caregiver, right, and for the care receiver, what's important to highlight is what social support are they receiving. So whether you're working with somebody who's a caregiver or a care receiver, think about that as a culmination of ways that could buffer the stress. Okay. So the other piece that I wanted to highlight here as this last component is, we've talked a little bit about this already, but I want us to think about this even as we think about what do we do as we walk away from this conference. And one of the key pieces is I want us to have a good theoretical understanding of intersectionality, and that it's not just a culmination of multiple identities or diverse identities, right? Intersectionality is really a robust theoretical framework that has emerged over decades of scholarship. And it behooves me to really think about the work of Gloria Anzaldúa, to think about the work of Patricia Hill Collins, think about the work of Kimberly Crenshaw, and that, you know, it wasn't just Kimberly Crenshaw who just coined intersectionality, right? Or Patricia Hill Collins who was talking about intersectionality in sociology, right? But that the Combahee River Collective, Bell Hooks, Audre Lorde, Angela Davis, Sheri Moraga, that they were all forerunners as a part of this movement, right? That when we trace intersectionality theory and research, it traces back to several decades. It's not something that just showed up, right, when Kimberly Crenshaw coined intersectionality. The other piece here that I want to highlight, because I'm looking at the time, is that when we think about the key pieces here, so we're talking a little bit about relationality, right? So what I want to highlight with relationality is that, so we've spoken a little bit about this related to older LGBT plus adults of color. One of the key pieces is that when you think about that relationship, it's not just a relationship between identities. So that's an important part. We want to affirm that because that actually can serve as a point of resilience because we affirm those intersections. Skylar Jackson and colleagues actually talked a lot about this, where they looked at a sample of Black LGBTQ participants, and by affirming that intersection, it actually it not only reduced symptoms like psychological distress, but also like improved overall outcomes, right? So there's that piece. The one other layer I want to highlight with relationality is really understanding, so how do I start tackling and thinking through what some of these policies or what some of like the barriers that might exist on a larger structure, right? So whether that's like in my agency, whether that's in my training, I really want to think about, okay, what am I doing that addresses the larger system, right? So that's because when we think about relationality, it's the relationship between racism, heterosexism, ageism, genderism. And today I didn't even mention, right? Like, but that is going to be an important part of our conversation moving forward, is ableism and classism. The other piece here is understanding complexity. So when we think about affirmation, right, and survival, knowing that, not only realizing the complexity in our lives, but also embracing that can be really powerful. And so knowing that, just because I am a queer person of color doesn't mean that I'm going to have the same experiences as someone who shares the same social identities that I have. So I think that there's something that, gives us this affirmation of our unique social identities and really helps us understand that, this is what has made us not only just like who we are, but also what has also made us resilient. So there's that piece with complexity. I want to highlight this because I think this is a larger piece of understanding intersectionality, is that moving beyond multiple identities and diverse identities, right, is that intersectionality really relies on social context and social inequity. So it gives us this map. It helps us attend to that map of what are some of these inequities, health disparities that we continue to see, and how do we continue to tackle that, whether that's in our interventions, whether it's in systems level change, whether it's in developing partnerships within our communities, or whether it's in finding ways to block policies, right, that could be harmful in the long term. The other piece that I want to highlight here is also related to power. So that's a key ingredient for when we think about intersectionality. Lisa Boleg talks a lot about this with, you can't have intersectionality if you don't talk about power. And when you think about this, right, power is used as this key ingredient of really understanding like which groups have access and which groups don't, which groups have power and which groups don't, but also which groups have essentially been living in a climate. What are the pieces of that climate that has granted certain groups power and certain groups who don't have power? Because it's not necessarily that I say I'm disempowered or I don't have power, right? Sometimes what happens is that the climate, the system itself, the social structure is what designates who has power and who doesn't, right? So, and that's important for us as practitioners and researchers to really understand, because it's like, where do we, with our social identities, might have the power, right, in order to begin creating these changes within the system. And last but not least, intersectionality is truly a fundamental social justice, active social justice agenda. So when we think about it, right, like now that we've kind of explored for social context, social inequity, relationality, complexity, and power, it behooves us to really think about how do I think about an active social justice agenda where I map out different interventions in the system. And remember, it doesn't have to happen overnight. So what it could be is a very thoughtful, emergent, systematic process of social justice interventions. So when I think about that, right, and what the the encompassing body of research around LGBTQ plus older adults of color, I think we have a map for so many different ways that we can tackle it. So not just policy, right, but when we think about healthcare training, we think about provider training, we think about culturally responsive care. How do we train our colleagues? How do we train um, our other like providers, right? Because as professional counselors, sometimes we might be in those positions as well. How do we also cultivate community partnerships? Again, like, so I was referencing that example of thinking through and even just initiating conversations, creating trust with community leaders could play a huge part. And the other piece too is really thinking about as we think about mapping all these pieces together and synthesizing it from the presentation today, thinking through how we want to, I was going to say, start to also like talk to or think about like even like housing environments. So how are we also working through, right? Like with care providers, so like who are like in like, for example, in assisted living environments or nursing home environments. The other piece too that I want to highlight is even for caregivers, right? How we're helping them navigate some of these like key barriers, because sometimes it's not, they might also be the tool in navigating those, like addressing those barriers, right, for the care receiver. So, with that being said, I want to say thank you so much on behalf of me and Nicole. And so thank you again for joining us today at our presentation. And I did want to leave you with our emails. So feel free to contact us, reach out anytime. Thank you so much.